Hello, everybody. Thanks for joining us today. I am so excited to have our guest today, Dr. Dahlia Rizk, who is a lot of things, an amazing doctor and the head of our hospital medicine program that really she started, grew when it needed to be grown, changed as it needed to be changed, and managed through an entire COVID-19 pandemic. She's kind of a legend here at Beth Israel, president of our medical board recently, so many things. Dr. Rizk, thank you for joining us.
Thank you, Dr. Weissman. I really appreciate the opportunity.
So, when we talk about hospital medicine, maybe the thing to do is to sort of start at the beginning. Like, what is hospital medicine? What do you do all day?
It's a great question, and it has evolved, honestly, over the course of my entire career. Hospitalists were formally coined hospitalists in a New England Journal article about 25 years ago, actually, this year. There were hospitalists doing that work before, but we really didn't have a name. And really what a hospitalist is somebody that really just provides the majority of their care in the inpatient setting. As you can imagine, care has evolved over time, but when you're admitted to the hospital now, more often than not, you will be cared for by somebody who is expert in inpatient care. We used to have specialists defined in organ systems like cardiologists, gastroenterologists, and hospital medicine kind of followed the trend of what emergency medicine and intensive care kind of specialty boards did over the years to define a specialty really based on where you are located in the hospital. So we're really caring for acute care patients that are admitted to the hospital setting.
And I'm a primary care doctor. I love that when I know that somebody who deals with inpatient pneumonia or whatever all day is seeing my patients. How do you feel like the patients and the families respond when they come in and they say, "Where's Dr. Weissman? I thought he was my doctor"?
Yeah, it's a great question. And there's been an evolution in that as well. So early on, I found myself having to explain very often to patients that their primary care doctor is making the time to be more available for patients in the office setting. And really, as the years have gone on, it's been more normalized for patients to know that the patients, when they come to the hospital, they themselves will be seeing people that are different perhaps to their primary care doctor, because care, quite frankly, has changed dramatically over the 20 plus years that I've been a hospitalist. We used to have patients here for weeks at a time for bed rest and urinary tract infections. And of course, that has changed dramatically. We have now observation units, which are very short stay units. And most of the patients that come to the hospital now really are very complex, have multi-organ involvement, are very, very sick, with rapidly changing clinical conditions that need to have a focus throughout that time that is very intense, with a lot of oversight and a lot of management with somebody that's readily available in the hospital setting. So for that reason, I think patients have appreciated the fact that there's somebody more expert in the inpatient environment to take care of them, that can be at their bedside in a flash if something is changing, or be there to speak to family members if there are questions throughout the day and night.
Yeah, I agree. I think it works for everybody. So when patients come to the hospital and they're sick and their families are there, are there things that patients should know or do to help make their hospital stay sort of go as smoothly as possible? Or are there things that we should be doing in the office or ahead of time when patients aren't sick to prepare them to be in the hospital?
Absolutely. I think it's a great question, and something that I'm often reflecting on when I meet a patient. So for example, I think as a primary care physician or any physician that sees a patient in the office, we really hope that you guys are having conversations. I'm sure you are. I know it's very pressured in that environment. But having a dialogue with the patient about their advance directives is so critical. We often see patients in the hospital that are almost startled by a conversation about advance directives and end-of-life care. It's not just for a patient that is elderly. Of course, this is something that is of value at any point in somebody's life. As we know, things can happen, especially as we saw this year, unexpectedly, with situations that put patients at risk for needing, advanced life support, for example. So having a dialogue with your patient is very important about advanced directives. If you're a family member as well, having that conversation when you're not in a pressured environment, when things are smooth and not in crisis mode, I think it's very, very important to really understand what your mother, father, aunt, or uncle would want for themselves if a situation were to arise where they would need some kind of more advanced treatment like intubation or shocking or artificial feeding. That's one thing that I think is very, very important and we should all be focused on. Another thing that I'm very impressed by when patients come in with a medication list, which is very, very important for the patient, I think for their own safety as well as for everybody around them. I've even been presented with a situation where I'd go across the street to grab lunch and somebody collapsed in the street. And I wish I knew something about them, about if they were a diabetic, are they on insulin? Do they have, some kind of an emergency contact in their wallet? So I would say for everybody, a very important point is to carry the names of the medications that you're on, including the doses if possible, as well as the names of the doctors that take care of you and your emergency contact. Those are critical for any caregiver to be able to access, all the information possible during an acute stay.
Got it. Now, you talked about pressured environment on the outpatient world, certainly a pressured environment in the inpatient world. Maybe this is a chance to think of, there's so much talk about, burnout and wellness and resilience in the, among hospitalists. What kind of stuff can we be doing and should we be doing? And if a resident calls me and says, hey, I'm thinking about going into hospital medicine, what should I tell them?
I often am presented with house staff that are asking that very question. I mean, myself, when I was graduating, I was trying to decide between primary care and a hospital-based setting when hospital medicine wasn't even a thing. So I would say the first question to ask yourself as a trainee is, what practice environment do you enjoy? Do you envision yourself as being more somebody in an office-based setting that has more of a direct relationship one-on-one with your patient, on an ongoing basis? It's more structured. There are appointments and times, for better or for worse. Keeping within that structured day, kind of is the format of an outpatient primary care practice. The hospital setting is more team-based, I think, in real time. Of course, team-based in primary care might be virtual or asynchronous, but team-based in the inpatient setting might be in real time, where you're calling on your consultants, you're calling on, colleagues in the emergency room or consultants at various places in the outpatient setting to come be at the bedside, for more information about their patients or to add and contribute for a new patient that they may have never seen before. You're working in teams for interdisciplinary rounds every day. We have that daily with social work, case management. You're working in teams with either APPs, what we call advanced practice providers like nurse practitioners or PAs. You're working in teams with residents, interns, and medical students. So that environment of working constantly in teams throughout your day and really not having the same kind of structure. Your day might be very, in your mind planned out, but everything can go haywire very quickly if you have one sick patient or if you have a difficult conversation or difficult situation that you weren't expecting. So the day could be feeling a lot more chaotic, whether it be meetings or multiple priorities, your texts going on throughout the day from various people that want to have more information. So you have to be comfortable in that dynamic setting and feel like you want to take care of sicker patients in this environment. So I think it's a very different place. Also, what has become interesting in the hospitalist world, there's a lot. We've evolved not just to be clinicians in the acute care setting, but also to have a lot of leadership roles in academics. So we have examples in our own hospital environment of leaders in the academic program for the residency. We have leaders in hospital medicine that, for example, our deputy CMO is a hospitalist, our chief patient safety officer is a hospitalist, people that lead service lines like the observation unit and other areas, for example, clinical site directors for the medical students, or that lead quality initiatives such as sepsis and readmission. So what I mean to say is that it's not just the clinical care. We have evolved to take over lots of areas of the hospital so that you can really develop a very dynamic kind of long-standing career in hospital medicine that isn't just focused on clinical care, that has a lot of different areas that you can develop yourself to have an impact on the hospitalized patient.
I mean, so it sounds like flexibility is like a key piece of this, and in part because of how difficult each day is, but in part how the hospitalist world is shifting over time. I know there's a bunch of new initiatives going on around ultrasound and addiction treatment, all these other things. I mean, what's sort of like the next frontier in hospital medicine?
That's a great question. We have evolved, and even terms have evolved with the hospitalists. We have nocturnists, which are dedicated night staff, and they're hospitalists that basically help provide care at night. It's become a niche kind of role. People that really enjoy the hospital at night, slightly different, a little bit more of the patient-doctor relationship, and kind of more of a slightly dynamic, response to acute situations at night, either with house staff or nursing. So that's one area that has really come to evolve over the years. Proceduralists, it's a term that has kind of evolved as well. You mentioned ultrasound. So hospitalists are becoming more expert in point of care ultrasound. More and more programs are training hospitalists to be leaders in POCUS, what we call POCUS, which is a bedside ultrasound that was traditionally, it perhaps was traditionally managed by an intensivist or by a radiologist, but bringing the ultrasound to the bedside by an internist that is now trained to do bedside procedures to help in real time diagnose a blood clot in the leg, a DVT, or perhaps some fluid in the lungs that can be distinguished from pneumonia for heart failure versus pneumonia. So proceduralists is like a whole other area. Triagists, we have a role that we call ED hospitalists now, and again, many programs have evolved to having an attending physician as opposed to a resident or a PA, kind of direct where the patient should go from the point of admission, whether it be a higher level of care like ICU, or to a surgical service with surgical co-management, or to a general admission, but calling the right consultants or helping to guide the house staff or the PAs at point of admission to the right plan of care. And we've seen a lot of value in doing that triage, or perhaps getting the patient home with a stress test the next day or into the office environment so that their primary doctor or cardiologist can do an echo or stress in the office, or none of the above because they've already done so on one or more occasion in the past. So we've even had our counterparts in nursing facilities, the SNFists, which are now hospital-based, or I shouldn't say hospital-based, but facility-based rounders, where, kind of a similar hospital model, for an internist on the inpatient side, but now like a nursing home might have an internist or a subspecialist that particularly rounds there in that environment. There's also colleagues in neurology, OB, surgery that are developing kind of hospitalist type models that kind of reflect kind of the change of the times, where, again, being available to your office-based practice has become very important in that environment, but also having somebody dedicated for acute changes on the inpatient side for surgical, OB, or neurologic patients. So.
Great. With all those changes, that's a lot of changes and a lot of stuff going on. I guess the biggest change, of course, is what happened during COVID, or at least during the first wave of COVID back, at the beginning of 2020. I'm sure you have a million thoughts about that. Take me back to what that was like, and what sort of the lessons that we can take away from that as we think about planning for the future.
Yeah, as you know, New York was hit the hardest very early on in the pandemic, and the uncertainty really of what was to come. Of course, many of our colleagues around the country are experiencing these surges right now, whereas in New York, we have a little bit of a reprieve, thankfully. But early on in the pandemic, obviously the uncertainty of what this disease was, what the impact would be on our shores, what we would need to do to protect ourselves, what PPE was necessary to keep ourselves and our families safe. I myself sent my family away because I really had no idea what the impact would be on them if I would be infected and bring that home to my young children. So much uncertainty, obviously, not just for the clinical providers, but also for our families and what that would entail. The collaboration was phenomenal. We had so much support from people around the country and from our own staff. People, as we know, we had no idea what was happening. Practices closed down, elective procedures closed down. We had to enlist the support of subspecialists, surgeons, orthopedists, people that normally didn't do acute inpatient care to help us manage patients that were hospitalized. It was, very chaotic. It was very hectic. We experienced a lot of pain and suffering, mostly for patients and their families, which was quite frankly overwhelming to see that much death and uncertainty in such a short period of time, because it was, although we had heard so much about it and we had followed closely what was happening abroad with colleagues, overseas, we couldn't imagine that this could possibly happen in a first world country, in our, advanced healthcare system in America, where we had all the resources and specialists available to us. And obviously, we were very wrong. This disease did not discriminate. And, unfortunately, we learned, what could happen with a pandemic such as COVID. I'm very proud of the response that our hospitalists, provided with acute patient care, and the collaboration and support of everybody around, nurses, our colleagues, and everybody. It was really an all hands on deck approach, and really could not be more grateful for that. The profession already experienced burnout before COVID, nursing colleagues as well, and COVID just really exacerbated that pressure, with burnout, and so much has highlighted wellness and burnout. COVID was just really the nail in the coffin, I want to say, no pun intended, to really put a bright light on how important it is to focus on the resilience and wellness of your staff. And we were able to do some really great innovation.
Right. You had some amazing projects around wellness, right?
Yeah, I think one thing we were great, we had several colleagues that helped provide gracious donations for iPads to the bedside, which really helped us, for example, to help patients and families connect, which was very distressing to us as clinical providers during COVID, to not have that family dynamic at the bedside to support people, especially at end of life and during critical illness. So that was very helpful. That key, innovation was very wonderful. We also had the opportunity to provide post-discharge surveillance by a phenomenal program that was supported by colleagues, Dr. Petrino and others, that helped us develop a programmatic, pretty much immediately stood up this opportunity to do remote patient monitoring on discharge, because we were finding that despite them being well on discharge, that unexpected things happened on discharge. And of course, we learned because of hypercoagulability and pulmonary embolus and stroke that things didn't always, turn out as we thought they might. We also, for the staff, had wonderful support of a colleague and friend, Morel Phillips, that helped put together a recharge tent, which was a conversion of what was a patient care area into a wellness tent. And that was just a beautiful, beautiful gift from her and Dr. Petrino again, who helped us develop spaces, both on an former inpatient room that was converted into wellness recharge room, as well as the tent, which provided really a sanctuary for us to decompress, even in the peak of COVID, for us to get out of the bells and whistles and sights and sounds of like this death and despair and go into a space that really provided us a moment to reflect, unwind, unleash our like inner like emotions, which quite frankly were at times tears or screams or just breakdowns, but were really much needed opportunities to just, you know, either bond, reflect, or take a moment to step back and get yourself recharged so that you can go back and face what you needed to face once again.
I mean, they are such transformative spaces, and it really is. I mean, one of the lessons for COVID for me was how generous people were. You know, at the beginning, when we were getting calls from doctors and nurses and staff all around the country pouring into New York to come and volunteer their services with us, it was truly amazing. And then at the end of that sort of first wave, being able to take this generosity and turn it into, you know, these recharge rooms for the staff, opportunities for staff to get together and vent and commiserate about this shared experience. I mean, it's really heartwarming. And, you know, I really thank you for taking the lead on so many of those projects. And I thank you for joining us today. It's really been a great conversation. I've learned a lot about hospital medicine. So thanks.
Thank you. I don't want to forget in the whole COVID response that the community support was just phenomenal. The claps, honestly, the food that the restaurants had provided for us, those were just like so heartwarming. And, you know, in our darkest moments, we remember just the community is it's just a wonderful environment to be. This Lower East Side community is very special for many reasons, but through COVID really helped us get through.
That's absolutely right. Such a great point and a good place to end. Thanks, Dr. Rizk. I appreciate it.
Thank you.